What I want to do today is in this last session, and now it's after the afternoon break, but you can all relax a little bit. I'm not going to be controversial or anything like that, so sorry, Twitter. This is really a clinical paper, and it's probably a marriage of two great interests of mine, tendinopathy and also that of chronic hamstring issues, and this is pretty much the group that I'm trying to cover here, and I guess I'm going to try and share with you more from a clinical perspective and whatever we do have out there in the literature of how we might approach these particular patients. So away we go. I'm just going to go a little bit on anatomy, and anatomy is boring, but anatomy still is the basis of so much that we need to consider. So again, I'm not going to read through all this, but one of the really interesting anatomical features in this quite complex origin of the hamstring enthesis is we have the sacrotuberous ligament here, which is obviously in series with the biceps tendon. And semitendinosus has a variable tendon. In fact, quite often it's actually just muscle tissue that inserts into the bone. So, and it really is very variable between people. But the one of greatest interest to us, of course, is the semimembranosus tendon, which is quite flat, but it arises deeply from up here. It's deep and lateral. And there is actually a little speculation at the moment that and you consider it's probably inflection and some adduction where there can be a sort of twisting and compression that area, a little bit like Jill was alluding to with the plantaris. But as I say, that's just a little speculation at the moment. But there's certainly a lot more to learn about so many facets of this area. It's an area that's been hard done by in the literature. There aren't a lot of articles, are there? So we're pretty limited in what we know in this area. What we do know, and again these are from surgical series, is that there's some variability in where people report the pathology to be. That Lempianen figures it's mostly from semimembranosus. Bonazzo thinks there's a distribution across both biceps tendon and the others as you see there. And again that could be just variations in their client group. The article we did with Tom Goom, I think, pulls out the fact that we're dealing both with compression, and we've heard a lot about compression today, Jill, and with others, shear forces and tensile forces. And it is this combination of forces as, you know, the hip joints put in all sorts of, I hope you didn't get that one, but in all sorts of funny angles within sport. And of course, then this places quite a deal of variable stresses through this quite complex enthesis. And it is truly an enthesopathy, if you like. It is at the tendon-bone junction. As you see there, there's cited to be some breakdown of the delineation between the tendon and the subchondral bone. There's bone edema and insertional clefts. And also, in my second last point there, it's the typical tendinopathy that Jill alluded to in her last presentation. You know, the increased ground substance, changes in collagen, changes in tendon cells. So no surprises there. Now there's a startling omission in this particular one, which I'll explain in a moment. But the typical presentations I've seen most recently in the desperate and dateless group that I have as well, Jill, are obviously the more Australian footballers and the rugby men. So both of whom do a lot of work in deep hip flexion or rucking over the ball or those things. But we see it less in our in the round ball soccer type football. I think because they're generally more upright, but that's in the group that we see. Middle-aged female runners are a big client group, and I think they have a couple of elements in their presentations that I'll try and allude to during the day. These non-athletic women, and a bit like the non-athletic Achilles tendinopathies, that they're not always helped with the load-based approaches, but it's certainly worthwhile, as Roger's last point in his presentation, that a lot of what we do end up seeing are these desperate and dateless non-athletic people. Sometimes all they need is a bit more load on their tissues and get them back into a zone where their tendons might be a little more capable. I've had a lot to do with race walkers, and hamstring tendinopathy is endemic within that group. But my bigger mission, talking to Suzanne earlier today, of course, is the 20-odd years that spent with our sprint hurdles group. And so sprinters and hurdlers are a very large group of these presentations here, so apologies for that omission. Our big challenge is that there are a number of pain-sensitive structures, or a number of structures that can present with pain in the general ischial region. And so the main thing is for us to try and work through in a very systematic and very accurate way, if you like, through our normal history and examination as to which structures might be involved. And this area, more than any other, tends to have its own individual presentations. It's certainly not one that you can give an exercise sheet to and off you go, because there's this incredible mixture of presentations that include or exclude neurological or sciatic nerve impingements, or issues with the other myotendinous areas, which I'll explain in a little more detail. The history of onset's generally insidious, as you know, and you know this well, but the two big groups that you want to try and pick out pretty early are those that have had an overstretch injury. This occurs in rugby league football, rugby union football, as well as their rucking, or the water skiing accident, or the overstretch in tennis. And these are the group that Carl Askling wants to bring forward, because of course we do need to know whether they have either complete or partial tears of the semimembranosus. And they take a lot longer to heal, as those of you who have read those articles. It is also a common site for, in fact, quite often the initial presentation for ankylosing spondylitis, so that the young male who often has quite stiff hips and or back, and has pain in their back at night, and other portions of their presentation, that's certainly something that you need to consider too. So, and these all happen, you know, it's not as though they're rarities and we need to forget about them. These present to all of us, and you're all primary contact practitioners, as I'm aware. How these athletes present with their pain localisation I'll cover in the resultant slides. We'll also talk about load response tests, a little different from what we have earlier. We're going to examine through this area. I won't spend time on this. We really want to hone on the hamstring tendon. And lastly, considering imaging. And as to Jill's point earlier, like, imaging is not something we do first, but it is something we might do to complement our clinical examination. And really, you know, it all has to make sense. So the imaging changes need to marry up with your clinical findings. Not uncommonly, as people age, that we'll see either age-related changes or load-related changes in or around the enthesis, which may not necessarily have anything to do with the pain they're presented with. And all in all, it comes down to clinical reasoning. You're all great clinicians, that's why you're here, that's why you're sports physios. And this area, I think, as much or more than most other areas, can really challenge and excite. And I really enjoy seeing this area, as you probably guessed. So, the pain sites. The typical pain site, of course, for our hamstring enthesopathy is just a little lateral and certainly posterior to the ischial tuberosity. And it's a very consistent site, both to where they will direct their pain and tell you where their pain is predominantly. But there are subtle differences from this that often direct us to other structures. The most common is people who get vague aches slightly lateral to that, and it may travel up and down a bit and be a little inconsistent in the way it presents. Not uncommonly, that's more these peripheral entrapments of the sciatic nerve, anywhere between through from the sciatic notch all the way down to as it passes under biceps. We see an adductor magnus, either a trigger point type problem, or they can get a true enthesopathy, and there is this true little tendon in there described by Obey, which I have on a subsequent slide. We get lumbar spine referral, which is pretty vague and whatever. We can have a biceps tendon disruption from the common tendon here, And we also have a little lesion that we see in semitendinosis in its posterior fascia, which can sometimes be of some interest to us because it will refer pain here for all intents and purposes. It presents like an issue, but you come up with negative provocation of the site itself and generally negative radiological findings too. So it's a matter of trying to pick all these things apart and then put them back together. Our provocative tests were described in the article with Tom Goom, and we'll generally start with things like a hamstring bridge. Does that produce our pain? How much pain do we get? Adding knee internal rotation, and if that increases their pain, we're pretty suspicious that it is that semimembranosus portion of that common tendon, because of course that's picking up the medial group. To get a high level provocation of compression, actually then going to things like arabesque. Another test that I like is that of Caccio's group. He uses 3 stretch tests, but I think the third is the most provocative when we're looking for something to really nail the hamstring tendon, where he takes people into maximum hip flexion and then adds quite fast knee extension, and whether that reproduces the pain in and around the hamstring enthesis. So they're things that we're able to use. They're things that, of course, we can come back and utilise as reassessment as well. I've discussed the imaging, and this is a normal hamstring enthesis here, and this is an abnormal one here. So that one of the first sightings one sees is this breakdown of the normal enthesial plate here, so that rather than being a really sharp margin, it is actually blurred and lost. We've got a little bit of intratendinous edema, we've got some peritendinous edema as well. Bone edema is not unusual, and we might imagine a little bit of bone edema here. But the other reason we can use MR, and MR is generally the modality of choice, is that ultrasound is pretty difficult to pick up and really delineate between too many of these structures. So it's more these axial MRs which are probably our favourite. Hernando and both Luis Perez describe these fibrous bands that exist on the deep surface of gluteus maximus, can wrap around the sciatic nerve and be tethered in any way there. And this is an issue. They're not always visualised on the MR, but they are something that gives us real problems with these sciatic entrapments, which is a whole other syndrome of itself, but I'll be alluding to it a couple of times in this presentation. Just the last one I didn't cover here is a delamination. These are pretty rare, but I'm going to look on the normal side. So it's the people who really tear away the origin of the hamstring away from the enthesis. So we see a pretty clear line of fluid in and around this area. These are rare, but David Young, one of our surgeons, suggests that they have a very poor conservative response and are generally best managed conservatively. I'd be interested in other people's opinions on that. So I've alluded to the differential diagnoses we need to consider, and the first one obviously are these sciatic nerve entrapments. I've probably covered a fair bit of that, but I urge you all to read the articles on the deep gluteal syndrome by Hal Martin. He brings forward a suite of tests that are pretty nice for, and he quotes both the sensitivity and specificity of those tests to be able to determine whether that's more provocative than what any of our hamstring type tests might be. And as you can see, we can have entrapments anywhere along that tunnel. I've also discussed so the article by Obey, which many of you might be interested in, that these certainly do occur and are easily picked up. And it's a person who comes in and you say, oh, where's the pain? And they're going immediately quite medial to the hamstring tendon. So I think that needs to be your first line of suspicion. There are a number of areas of sort of trigger points or myotendinous strains, or call it what you will, that do present through the external rotators, the gluteals and others. And these are all not atypical pain generators. Whether they're the primary issue or not is always one for great debate. But the big issue, as we sorry, I'll just go back. But the big issue that we have is that not uncommonly with the more common chronic presentations that we're dealing with more than one pathology. We may well have a truly hamstring tendinopathy, but having to manage areas within, the gluteal muscle group, the external rotator muscle group, and or the sciatic nerve or other structures is not uncommon. There's a number of rare syndromes that we need to consider at times when we're not getting our clinical results with others, and certainly in our desperate and dateless group that we might spend quite a bit of time trying to tease out these particular things, which time's going to prevent me spending too much time on those today, but I urge you to consider these when you've exhausted the top 3 or 4, and you generally start there. So they're there. Stress and avulsion fractures, often the avulsions obviously occur in youngsters, but we see people post-avulsion in their 20s and 30s wanting to sprint or play football and get ongoing issues from perhaps their early avulsion. So that's another group there as well. Okay. So here's what we're here for, which is to be able to share, and it's probably the only tendon we're able to share quite the whole approach to in terms of the rehabilitation. So I'll go through the 4 stages. You've heard all this before, so what are we going to do? We're going to unload the tendon. Well, how do we do that? Well, we take out the things that provoke it in training. Well, what might they be? Well, it might be our hurdling, it might be our sprinting, it might be our accelerations, it might be our change of direction. So depending on the sport, they're the things that you're going to be looking at first. Can you take those out? The other thing you can do is, of course, rather than participating in whole sessions, you can drop them back to half a session. So these are all means, pretty simply, of unloading the tendon. But of course, just resting or unloading is not where we need to get to. We actually need to get to actually reloading the tendon. The other thing, as I've said, is unloading compression. So it's anything of trunk on hip flexion. And lastly, and again, how many times have we said this today, team? But going through the kinetic chain. So what are the ways of actually sparing the load on the hamstring enthesis? And of course, the synergy between the gluteus maximus and a hamstring is probably the primary thing we need to consider here. We're then going to strengthen up our muscles. Again, no big, I was going to take out something there, but don't poke the bear is a term that we used and we weren't going to use today, but because bears are part of burn, aren't they? So it is taking the tendon to a point where you actually are going to poke the bear and actually increase its symptoms. So that was where it came to. But of course, you're all going to understand that, aren't you? Because you probably poke bears more than we do. And lastly, of course, the progressive loading, and that's what I really want to share with you today. So we've mentioned in others this monitoring the progress with the provocative tests, the 24 hours after your high load sessions. It's all the same here. So again, this should be sit back, relax, enjoy the ride, and nothing that you haven't heard already today. Ebony showed you this slide, and this is really about finding positions that we're going to get our early isometrics in. So we really don't want to be getting pain with the isometrics, or we may get a little pain, but when we retest with our provocative test afterwards, which might be our hamstring bridge, we want to know that isometrics have actually reduced their pain, maybe not to 0 in the single session, but 1 or 2 sets of 45-second holds of one of these has actually changed their pain. That gives you reassurance and also your patients reassurance that the hamstring tendon or enthesis is a part of this. Our big challenge early was how do we get big forces into a hip neutral sort of position? And so we started with things like having we call this a trunk extension machine, or some call it a Roman chair. We can do double leg holds with weight, but we really, as Jill alluded to, and Ebony, that we want to get to single leg holds pretty early. To get Franz Bosch eventually gets to people in this sort of position plus 70 plus body weight pretty much, but we tend not to take people that high, but of course you'll go as high as you need to. Or isometric holds in a machine. Our issue is that most people don't have these machines at home. And we want to do them 4 times a day. So then what do we use? We use our long-legged bridge, and you can actually get them to just bias it to the affected side. And that way, you're actually able to be reasonably effective, and you get pretty fair loads early. So that's what you would be using at home, and any time they can't get to the other equipment. We can use an internal rotation bias if you really think that it is the semimembranosus portion. The second stage was about strengthening the muscle. Jill talked of this earlier today. I'm not going to tell you how to strengthen muscles. You do this all day, every day. But you know the principles. That what we want to do is sets that induce lactate. So, 3 or 4 sets where it's 3 or 4 seconds up, 3 or 4 seconds down. And you're doing 6 to 8 reps. So that the overall duration is about 60 to 70 seconds. That's going to induce your lactate. Partial recovery, go again. We need to do it at least 3 sessions a week, and we need to have it's not just a single exercise, it's a suite of exercises that really tackle the hamstrings. There are your options. We might, after listening to Ebony, and I listen to her a lot, so I really like using isometrics pre-session to train our brain to get maximal activation of our hamstrings. So this is a very important part. We might also use TNT. As a means of utilising that. So again, let's adopt all of these things. Of course, if we need to strengthen glutes and other things, we'd be doing that in the same session too. Jill had this in section 3. It doesn't matter whether it's late stage 2 or section 3, it doesn't matter. But here we're starting to reintroduce compression. Okay, so we're getting exercises where we're not doing fast movements initially, we're doing fairly slow movements, but we're starting to introduce that compression of trunk on the trunk on hip, where we're starting, what happened there? Where we're starting to get increased flexion and increased compression at the joint. So we can do things like just lateral sumo squats, and we can gradually increase compression and gradually increase compression as you do it. That makes a lot of sense. I use the sled drag, the sled push quite a bit, where we can do just repeated pushes. We can weight the sled up, and I'll show you what that looks like later. But of course, we can then get more and more hip flexion as their symptoms are telling you they can tolerate. So we can really grade our compression quite nicely. And that's why I like these exercises. You can be quite accurate with the way that you add compression. Walking lunges are another good way. So again, all these things that you know well. And it's only very late stage that you might look to provoke them if their sport requires it, to have to go into full deep hip flexion, so they might go to single or double leg leg press. But if their sport doesn't require it, don't do it, because it's just going to add pain, add length to your rehab that you really don't need to do. Stage 3, adding speed. Same principles that we spent all morning talking about. So controlling range early, and in fact often you'll bring them back out of their range a bit as you're starting to add speed. So what are things that we might do for the hamstring tendon? Things like box jumps, things like faster sled, where we're starting to really push along. And I'll show you what this looks like by far more athletic people than me. We did some analysis in that same group that we talked about before. I love scooters, I love run-throughs, I love acceleration. So all of these things. 3-day load cycle, again, you've learned about that before. So this was an analysis of doing the sled and what's happening at the, and again, you know these quite well, but what's happening in the sled at the, when we do a slow sled, a fast sled, and then the third step of an acceleration. And you can see here, not much difference in the tensile force, but the big difference is in the rate of loading. And the rate of loading with our fast sled is pretty much where we get to with maximal acceleration in highly trained sprinters, highly trained runners. So that we know that what we're doing in the gym, we can increment between here and here to take us all of where we need to get to. So I think that can be reassuring too. So now we're becoming more informed in this sort of exercise we do. One thing we did find in this testing though is that we need to consider the friction. If we have less friction here, of course, we get less peak in force, and we can gradually add friction as your way of loading that tendon. Stage 4, again, just looking for activities that's going to take them all the way back to their sport. The really important thing is don't overload these incremental things. All we need to do is a little bit so they can get back to whatever sport they need to do. The really important thing is that once they resume sport or resume the training, take out all these high load activities. Jill showed you, I think, a slide where when we added high load activities or eccentric exercise, in fact, to people who are already training, that of course they in fact got worse. And the same happens here. So really important in this sequence that we remove some of our other loads as we're working back into sport. Kinetic chain, we know well, and as I've alluded to before, the big thing is gluteus maximus is the big synergist with hamstrings. And in fact, I discussed our middle-aged running women, and so many of them, when we see them, actually are quite strong in their hamstrings, but their big problem is that all they use is their hamstrings. And they often have if we ask them to do a hip extension, they can't fire their gluteus maximus at all. I'm talking at all. And so much of the approach is in fact trying to strengthen their glute max through hip thrusters and other things, rather than spending all our time on the hamstrings. So I did want to make that point. We've got a rig now that we use, is a force transducer down here and a strap where we're actually able to quantify hip extension strength and look at the relationship from side to side, and also its relation to knee flexor strength as well. So we're starting to get some normative data with that, which you'll see in the coming years. Same picture. So overview. It's a multimodal approach to management, and that sometimes in concert with our doctors, we're looking at using medications and or injections to hit some of these other pain generators to really clarify the picture for us so that we can get back to concentrating on the hamstring tendon and its rehabilitation at time. That really it is about effective tissue loading and quite considered loading over time. These things do take time. This hamstring enthesis is generally not slow to rehabilitate, but none of them are. And it is really about lots of accumulating load over time. And I've said that. So happy endings, there's two things that really worry us. So introducing compression too early, and sometimes you need to back off that. Keep going through other progressions and then reintroduce compression later. And then this elastic function in the late phase. It's an area that, again, can become a bit intolerant. And this relationship, and I didn't spend, and I can't spend time talking about the sciatic nerve, but there's almost another lecture you could give around strategies for the sciatic nerve and settling that down, which you're not uncommonly needing to do in your rehabilitation here. So that's it from me. Again, thank you very, very much for the experience, and Mr. Chair, back to you.